Hello, welcome to Physician Academy. Today we're going to talk about chronic kidney disease. As with all lectures at Physician Academy, they're meant for physician-to-physician education purposes only. They're not meant for any other use. So all physicians should use this as needed. They're welcome to comment if they find something that's in an error and they wish to correct it, or if they'd like, they can contribute their own lectures. Chronic kidney disease is categorized as a diminished renal reserve. In other words, your renal function is dropping off over time. It's also called renal insufficiency, or renal failure is the end stage result. So as your kidney function drops off over time due to a variety of different assaults on the kidney, it'd be considered a form of chronic kidney disease. So chronic kidney disease is common in medical patients, resulting from other medical problems that are damaging the kidney. The most common one is diabetes, which we talked about, type 2 diabetes, type 1 diabetes, hypertension, which our other lectures are on, glomerulonephritis. Other causes can be renal artery stenosis, ischemic nephropathy, vasculitis, focal glomerulonephritis, all sorts of different problems. Anything that would cause damage to the kidney and continue to cause damage to the kidney over time would be a cause of chronic kidney disease. It's a progressive loss in the kidney function over a period of months or years. The symptoms of worsening kidney function are not specific. Most of the time covered on routine blood tests showing elevated creatinine levels in the blood, very common in a basic metabolic panel or a complete metabolic panel. And you'll notice it in your patients that the creatinine is steadily going up over time. There's not a lot of symptoms to the early stages of chronic kidney disease. Most patients don't even realize they have it. The type 2 diabetics, which are commonly seen in most practices these days, won't even know that they have chronic kidney disease. Neither will a lot of the hypertensive patients. So there are very minimal symptoms at the beginning. As time goes on, they develop other symptoms. Azotemia, meaning urea accumulates in the blood. Potassium may accumulate, so you get high potassium levels. You get low calcium levels, or hypocalcemia. Metabolic acidosis can also occur, and hyperphosphatemia. These are all signs of progressive kidney disease and can be indications of kidney failure and a time for dialysis. Recognized complications such as cardiovascular disease, anemia, pericarditis are also other things that can lead to more chronic kidney disease and more damage to the kidneys. How do you diagnose chronic kidney disease? Well, there's a clinical evaluation, of course. Everything should start with a history and physical so you know what's going on with the patient, as well as blood work. Commonly, it would be a complete metabolic panel as a routine test, and we'd be looking for elevations in BUN, creatinine, potassium, calcium, other factors that might also lead to issues with the kidney. Another test that should be done would be an ultrasound, and we're looking for structural problems such as cysts, stones, and also renal vascular disease. So we're looking for stenosis of the renal arteries. Elevated creatinine can be used to get an estimation for the GFR. And many of the labs these days are even offering an estimated glomerular filtration rate, or GFR, with your CMP or BMP. There is a nice formula for the GFR that requires the serum creatinine. There's correction constants, as well as correcting for being female, male, or African American. So once you have a GFR, an estimated GFR, the stage 1 is GFR of 90 or more. Stage 2 would be a GFR of 60 to 89, indicating mild disease. Stage 3 would be a GFR of 30 to 59, mild to moderate disease. Stage 4 would be a GFR of 15 to 29, indicating severe disease. And stage 5 is a GFR of less than 15, which is renal failure. Protein in the urine, or proteinuria, is another gauge for the disease severity and used to follow progression of the disease. And often in diabetics, we want to get a microalbuminuria because proteinuria doesn't show up easily. And that would give you an idea that the disease is starting to show kidney damage. Patients with a nephrotic range proteinuria that's greater than 3 grams per 24 hours or urine protein creatinine ratio of greater than 3 usually have a poorer prognosis and progress to renal failure more rapidly. So how do you treat chronic kidney disease? Well, you're not specifically treating the kidneys. You're going to specifically treat the patient for the causes of the chronic kidney disease. So obviously, if they have high blood pressure or diabetes, the better we control the blood pressure and the diabetes, the slower the progression of their disease. Another treatment that's important is vitamin D supplementation. You also need to treat the heart failure and any anemia if present to improve renal perfusion, and dialysis for heart failure, uremia, or hyperkalemia as needed for renal failure. Chronic kidney disease requires adjustment of medications. That's another really important thing. That's why we need to identify chronic kidney disease, is because often we need to give less of our medications. Other issues to be discussed at later talks would be chronic kidney disease and mineral bone disorder, something that's newer, glomerulonephritis, and of course nephrotic syndrome. These are all lectures coming soon.